next session will be on otosclerosis, and I request Dr. Colonel Ajay Malik sir and Dr. Debashish Barman sir to start the session.
Hot, humid Kolkata afternoon to sit down and be, literally fed about information, but I think that is the beauty of medical science, isn't it? And especially if your exam going, right? So we'll discuss without much ado about otosclerosis. I am Dr. Ajay Malik. I am the professor and head at AIIMS Kalyani. I will be discussing the initial part of the otosclerosis, and Dr. Debashish Barman will take on the surgical aspect of it. Now, what do you know about otosclerosis? Anybody? Last row. Where's the mic? Anybody? Everybody's heard this term. But if you are asked to write about otosclerosis, a small note. So what will you start with? Otosclerosis is somebody. I know you know it. Just come out. Anybody? Okay. One. She added localized. Hereditary. Anybody else? See, whenever you describe something in medicine, what is it? Where is it? Embryologically where? Yeah. So you please see that you are covering all the heads. Why is it there? Okay, then that means a bit of the etiology. So in this case of generally it is a hereditary or an unknown etiology, right? And what is it causing? So if you write these 4 or 5 things, your definition is complete. Clear? So in the definition, I think you all covered it very nicely. Hereditary important. Primary disease means, when you use a primary in medicine means what? Very nice. Otic capsule characterized by pathologically absorption, resorption, which was again told by you. Macular bone replaced by unwoven, increased cellularity. Okay, so this is, I think, covers up most of it. I have not mentioned about what does it cause. So next, what is the etiology? As we said, the first thing you write in bold letters, it is not known. But we all know there are multiple etiologies. So one of them is, of course, genetic disposition. Then there is a female to. Why genetic? Because there is a female to male preponderance, usually seen exaggerated during pregnancy. Measles vaccine, measles has been told about it. Autoimmune is everywhere. Biochemical changes are there. And of course, you have hormonal. Lately now, everything is going towards genetics. Okay, so everything is going towards genetics. So you have, not very clear. Is it? Can you read from there? Okay. So pathological deletion in FOXL1, which is the first otosclerosis gene which has been isolated. This is just for recent advantage and getting those brownie points. And this is in a 2021 Human Genetics, which is a very good journal. 2021, this has been published. So histopathology, as rightly said, there is resorption of bone by the osteocytes, formation of new bone. That's good, no? So what is the problem? Bone is being resorbed, bone is informed. Isn't it natural? So what is the problem then? Excessive deposition of what? So basically what is happening, the good bone is not being formed, which a disused bone is being formed, okay, in layman's term. So we put it as formation of new bone, which is a spongy kind of bone. Then it forms sclerotic bone, and then usually larger, like she said, it is larger than the one it replaces. So that causes the problem of, what is the problem in the physiology of otosclerosis. Clinical features, somebody? This side? 1, 2, 3, 4. How do you start? Very nice. Progressive hearing loss. Okay, somebody else? Later on. First start with normal, then go around. See, if you're talking of a head and neck tumor, you talk of the symptoms what that tumor will cause and just keep going around, your answer is complete. Okay, you don't need to read up and mug up anything, right? So basically the first thing you have to say is hearing loss behind an intact tympanic membrane. Please remember that. Clinical presentation, age. So whenever you write a paper, what is it you write, na? Age, like a history taking. Those same points will come here also. Slowly progressive, bilateral, increase in pregnancy. Now you start with the other problems, right? That is tinnitus, paraacusis villi, I think need to be told. Everybody knows. What is it? Somebody can just tell from here. What is paraacusis? You hear better in a noisy environment. Excellent. Then you have vestibular symptoms. You can go on to that. Very important is next history what you take is family history, isn't it? Past history, family history. You come to family history of deafness. So when you are giving these clinical features, just imagine you are writing a case sheet. All the points will come automatically. Okay? You will not miss out any point. And then finally you have a history of trauma and recurrent URTI is absent. Please remember that. That absent negative history is also taken, isn't it, in a history? No history of this. So that also has to be mentioned. Now we come to a term which is cochlear otosclerosis, which can come as a short note to you. And cochlear otosclerosis is what? It is again located in otic capsule but involving the cochlear endosteum and therefore causing, instead of a conductive, you get a sensorineural kind of hearing loss. And now reverse can also occur. You have a SNHL and then it becomes mixed because when it cochlear thing spreads, it comes and hits the stapes. Okay, but this is just something you can know. Like they say in medicine, nothing is 2 and 2 is not 4. It can be plus minus also. So what are the criteria for diagnosis of cochlear otosclerosis? Who will tell me that? This is the first division question. You get this, you get 60 plus. There are so many points. There are so many points in a cochlear. Cochlear otosclerosis can come as a short note, please remember. So you have a progressive pure cochlear loss beginning. As we said, it can go on to otosclerosis. You have unilateral consistent of bilateral SNHL, positive side sign, positive, everything you have to mention all these points. Okay, this will be given to you the slides. We are running out of time, so I'll just hurry up. Examination. What are the points you can cover? Somebody? Middle rows? I told you one already. What is it? Next. Otosclerosis. What is it called? What sign? Short sign. Good. What else? It's also known as the flamingo pink. It looks like a flamingo pink color. So it is that on the anterior part of the, this is how it looks like. Okay. You get this over here. Tuning fork test. Who will take on? In a theory paper, you have to add something more than Rini, Weber, ABC. Carhart notch is not on tuning fork. Carhart notch is in ETA. So start normal basics here. Rini. Rini kya hoga? What will be Rini? Come on, conductive hearing loss. So you will get a Rini. Rini negative. Weber. Conductive hearing loss. Lateralized to the worse ear. We said otosclerosis is bilateral, isn't it? So you have to say it is going to the worse ear. ABC will be normal but reduced in cochlear otosclerosis. Then you have two more tests just to finish it off. You have a Bing test and a Gelli's test, which is, I have described it how it is done. You should know if somebody asks you this, it's okay. Otherwise, it's generally not done nowadays. Audiological features. Now this is important for you. You just had a class beautifully taken. I think most of the things were covered, right? So recapitulate, tell me, what will be the audiological features? Someone from here? This side. Carhart notch. Okay, fine. What else? So what is Carhart notch? Dip at in the bone conduction. Sir was repeating this to you people, isn't it? Bone conduction, bone conduction, bone conduction. So you have this. Okay. So initially there will be loss in the lower frequencies. Then slowly you start developing, and then later when the disease progresses, you move towards a mixed loss and a SNHL component comes in. Now what are these terms? Stiffness, tilt. This is just to, again as I said, these are extra points which you get when in a theory paper. It is nothing different. It is just that it is a rising audiogram. This kind of a thing is called a stiffness tilt. Just a term, okay, nothing different. What you have been told and what you have been not taught. And there are two terms. Is a cookie bite pattern. Cookie bite, dekha na, if you see a child how it takes a biscuit bite, in the middle it takes a bite. Okay, so it looks something like this, as though the bite has been taken here. Okay, so that is called a cookie bite. Development of mixed hearing loss when it comes is as though a bite has been taken in the audiogram. So these are just two terms. Write it, underline it, you get a +1 +1. So tympanometry, already known, AS curve. Add one more thing, very important is this, I want to know. This is the earliest sign of otosclerosis. The on-off effect on, or the diphasic pattern is characteristic of an otosclerotic focus in the ART. Now I have written an SSSD. What is the differential diagnosis? What will be the difference? So what is the difference? What do you get in SSSD? Low frequency, what type? Yeah, it is in, please remember, there is a paradox. It may sound as a superior semicircular, and don't expect SNHL loss. It is a conductive hearing loss, same as otosclerosis, isn't it? Intact tympanic membrane, conductive hearing loss, low frequency, but here you have a ART present, and in the otosclerosis you will get the ART which is absent. Any other differences? This is a clinical judgment. See, you will get the same, you may get the same curve in SSSD. All the tests will be normal, and you plan a otosclerotic, thinking it is otosclerosis, you get a piston and then you find everything is normal. So what is the other things in SSSD? Okay, fine. Fistula, start clinical examination first. Fistula test, 1, 2, third, very important. Classic, told you in the last class. One sentence was mentioned over there. Okay, I'll come to that later, then you will recollect what was told in the last class. I was sitting and listening to that. Sir had mentioned that. Radiological features, okay, when do you do CT scan? I know private practice nowadays, everything CT scan becomes a CT kya, MRI bhi karoge ab. But as a clinician, do you have any criteria of doing a CT scan where I must do it? Forget the angle nowadays when you are doing. Very nice. When the patient has got SNHL component 1, second. Quick. Unilateral is so what? Unilateral conductive hearing loss is there. Which under condition you will do a CT scan before sitting and thinking and operating. Given you the hint. I have given you the hint. Meniere's disease, how do you know? Vertigo, yes, symptoms he is told that part is covered. The patient is operated and now he is come back with a you all are getting stuck here only. SNHL component. SSSD we just discussed. What is PLF? What is PLF? The patient has been operated, he is coming back with fluctuating hearing loss. The piston may be going down, or he comes with a recurrence. You have to go and see before you operate what are you going to deal with, right? And revision or a fistula. Okay, air bubble is basically in a CT scan you will get an air bubble in the thing. You know you are dealing with a case of perilimb fistula. So please remember this. Actually, when nowadays of course indication is every case you go and especially in private I think you do a CT anyway. Now what are the findings? Anybody? There is some criteria. Yeah, louder. Very nice. Simon and Frenning criteria. What is it? Now, before that, tell me the findings. This is something which at your generation you have to know. You may not know a Bing test, you will be excused, but you have to know CT findings. Clear? So please take this seriously, not only for the exams, later in a practitioner you have to know these things. So this is active otosclerosis. You get an hypodense area anterior, generally that is in the anterior part, you know that. So you get a hypodense area, foot place will be thickened, narrowing of the round and below, and this is important, which is called a double ring or a fourth ring of Valvasori. What are the other rings of Valvasori? Go back and read up. Then what are the modes of CT? What CT do you do if you are given the choice? Anything specifically you can write nowadays, CT scan? Yeah, somebody said that. Very nice. You have a cone beam, you have a SPECT and you have CT densitometer. What is the difference? What is the difference between these three? Lesser cuts, less radiation, right? Very specific. SPECT is single photon emission CT. Dynamic technique, you get the bone activity also. Okay? And what is a CT densitometer? Sorry. CT densitometer is qualitative assessment of the cochlea, right? Go back and read it. These are the newer things which you have to mention in a CT scan. And grades, like he correctly mentioned, there is a Fanning and Simon 2005. You have a grade 1, grade 2, ABC and a grade 3. So, okay, depending on the turns, basal turn, middle or the apical turn, you have 2 ABC and then you have this. Don't note it down, you will get it in the video. MRI indications, like in CT, now tell me. Contemplating CI, I will come to that later. What is CI? Contemplating CI, perilimb fistula, or you have a labyrinthitis ossificans. I will come to that just later after this. Differential diagnosis, all diagnosis of conductive hearing loss will come under the differential diagnosis. There is paucity of time, so we will not go about, but quickly start from the external ear, keep going inside, okay, till SSSD. So this is a congenital fixation, middle ear effusion, it's long list. What I was trying to tell you, you said about the fistula test, you had ART present, but please remember this, bone conduction is in minus. Okay, if you have the bone conduction as 0, if it is going to -5 minus thing, think of SSD, right? Please remember that. Then another differential diagnosis, besides the local causes, you have a systemic causes. Any two causes, anybody? Paget's and osteoclast. What is this classical picture? OSCE question. This is an OSCE question for you. You have Paget's and osteogenesis imperfecta. Now what is this term? Who will tell me the features? Short note, 100% short note. Take it from me, this short note will come to you. Hearing aid alone not effective. Please remember that. That is why in that MRI slide I had written contemplating CI. Which cases? These cases. And what is the management? It is not one modality. You can't just give a hearing aid. You can't just give a surgery. You can't just put the piston and say that is the end of it. Right? That is the basic thing how this term came. CI is the best, and remember this term. Recent advances, DSES, DAX. Okay? I think sir will be discussing on all this. So this is how you manage a case of recent advances in advanced otosclerosis, basically far advanced. Hearing aid, perform this, cochlear implant, scalar tympani, scatar willemensation or a this thing, okay? Treatment, observation, hearing aid, medical treatment, surgical treatment. Medical treatment, anybody, quick? What is the aim? Why do you want to give medical treatment? Very good. To stop the, arrest the bone resorption. Stabilize the disease basically, okay? And increase the osteoblastic bone formation. What do you do? What are the things available to you? Sodium fluoride, everybody knows. Vitamin D, vitamin, anything else? This is the phase 3 trials. Biphosphates are known now. Third generation bicuspid otosclerosis stabilized as a long-term follow-up. 2017 laryngoscope. Please remember this term, biphosphates have come in now in the treatment of otosclerosis, and I think now I hand over to Sir, and then Sir will take on from here on the surgical aspects of otosclerosis. Any questions? 2 questions. Anybody? Thank you.
Now regarding the treatment part, mostly the surgical treatment. Before starting the surgical treatment of otosclerosis, usually otosclerosis case is not given in your as a long case or short case. But many questions can be asked in your oral section, in osteology section, in radiology also, in short case, etc. Before starting my session, I like to thank my sincere gratitude and pranam to the living legend of stapes surgery. Professor B.K. Rai Chaudhary is sitting in front of me. So with due permission from Sir, I am starting my session. What are the different types of stapes surgery? You may be asked in your oral table. Tell me a few lines about the evolution of stapes surgery. Rosen in the year 1952 first starts the stapes mobilization, but again it gets refixed. In the year 1956, Shia first did the total stapedectomy. Original stapedectomy means he excised the whole foot plate area and put a tissue graft, and he used polythene stud from the long process of the incus up to the vestibule. After that, partial stapedectomy was performed by Plester. He did the excise the posterior 1/3 of the foot plate and put a polythene stud from the long process of the incus up to the oval window. Then Shia 1982, small fenestra stapedectomy. Most of the surgeons in our country are performing the small fenestra stapedectomy, means making a control hole in the foot plate. There are various advantages also for making control hole of this foot plate. After that, a tissue graft or any vein graft or perichondrium is placed over the graft, and then piston is to be applied. Various type of pistons are to be discussed. Reverse stapedectomy means you make the control hole before removing the superstructure of the stapes foot plate, and there are some advantages also. Neostapedectomy, as Sir has described, probably in the year 2007, without dislocating the incotostapedial joint and without cutting the stapedial tendon. There are some advantages also of doing neostapedectomy. Stamp procedure means stapedectomy minus prosthesis. Here laser is being used, mainly the argon laser. Silverstein in the 2002, he vaporizes the anterior 1/3 of the foot plate, including the anterior crura. And then the foot plate gets mobile and the posterior cross is being used as a prosthesis. That is the stamp procedure, and there are other techniques also. Now, what is stapedectomy advantages and disadvantages? It is a relatively easier procedure, good closure of the earbone gap, better low frequency hearing gain in stapedectomy operation, but disadvantages are there are more traumatic to inner ear, decline in the hearing over time, and more chance of sensory hearing loss due to more trauma to the inner ear membrane. Advantages and disadvantages of the stapedectomy: less traumatic to inner ear, stable hearing gain over time, and better high frequency hearing gain, but there are fewer complications also, but it is a disadvantage, is technically more difficult to perform. Fenestra. What are the sizes of the fenestra? It may be small one, it may be medium size, it may be large fenestra stepidotomy operation. Regarding preoperative indications, preoperative medication, preoperative counseling is a must before doing stapes surgery. All the patients should be offered about hearing aid. Hearing aid is the other option apart from surgery. So and patients should be counseled about the postoperative hearing loss, postoperative vertigo, postoperative facial nerve palsy, all these to be explained to the patient. After pre-medication anesthesia, it may be most of the patients, about 99% patients are doing under local anesthesia, except apprehensive female or children, GA is required. Now, how do you infiltrate the canal? This may be asked in your examination. There are various, usually 2.2 ml of lignocaine is mixed with 0.3 ml 1:1000 adrenaline, making 2.5 ml solution. You take in a syringe, 0.5 ml is injected in all the 4 quadrants of the canal, and 0.3 ml is injected in the postal groove for taking subcutaneous tissue as a harvesting seal, and 0.2 ml is instilled into the middle ear, because after elevating the flap, middle ear is not anesthetized, but all the material to be sucked out. So no anesthetic agent should go into the round window. What is the principle of stapes surgery? Restoring the impedance transfer of ossicular chain and acoustic impedance of the annular ligament of the stapes foot plate in order to achieve normal physiologic vibration of the inner ear fluid. Indications: unilateral or bilateral conductive hearing loss with a bone conduction level 0 to 25 dB in the speech range and ear conduction level 45 to 65 dB, and the ear bone gap should be at least 15 to 20 decibels. Speech discrimination score should be more than 60% and negative Rini test in 512 Hz. These are the indications. There are other indications also. Tympanosclerosis as a second, stapes surgery is performed as a second stage procedure, and few cases of congenital fixation of the stapes foot plate where other middle ear anomalies may not be there. What are the contraindications of stapes surgery? Only hearing ear, and second ear surgery if the operated opposite ear had some complications intraoperatively like perilimb gusher or postoperative period vertigo or central hearing loss. And there are also relative contraindications are otitis externa, otitis media, cholesteatoma, etc. Many people have transferred from microscope to endoscope in doing stapes surgery. There are some distinct advantages also by doing endoscopic stapes surgery and disadvantages also. So what are the advantages of endoscopic stapes surgery? Better visualization of the whole the incutostapedial complex, 360-degree panoramic view of the middle ear, and minimal overhang to be cured in comparison to microscopic stapedectomy, and lesser manipulation of the chorda tympani nerve. What are the disadvantages of endoscopic stapes surgery? Lack of depth perception, possible thermal injury to facial nerve or chorda tympani nerve, ossicular dislocation sometimes may happen, and difficulty in placing the prosthesis due to lack of depth perception. Now, surgical technique, as you know, Rosen incision is given about 4 to 6 millimeter lateral to the annulus, but you must remember the superior incision must go anteriorly behind the long process, behind the long of the malleus, as because sometimes there may be fixation of the malleus, fixation of the anterior malleolar ligament. So anterior bony rim is to be cured out, and fixed anterior malleolar ligament is to be cut. Then removal of the bony overhang for adequate exposure. What do you mean by adequate exposure? Throughout the long process of incus, whole stapes superstructure including the foot plate, pyramid, facial canal is to be visualized. So what are the limits of curate? Superiorly up to the long process of the incus, but not to open the body of the incus. Inferiorly up to the base of the pyramid, and medially horizontal facial canal, it should be visualized. Now, after diagnosis, how do you check the mobility? All the 3 ossicles are to be checked individually. because sometimes malleus may get fixed. So malleus can be palpated from medial to lateral direction, and the movement can be seen at the incudostapedial joint, and the round window reflex will be absent. Similarly, incus mobility to be confirmed, and stapes superstructure is palpated in superior to inferior direction, and associated malleolar fixation 1% may be missed. What is the importance of making control fenestra? The purpose of making control fenestra is for identification of the perilimb gusher, to prevent vestibular shock, that is sudden increase in vestibular pressure causing vertigo. Number 3, to prevent acoustic trauma due to accidental fracture of the foot plate while removing the stapes superstructure. But making control fenestra is not possible in obliterative otosclerosis. Besides this, control fenestra avoids the rupture of the new vessels in the otosclerotic focus, particularly in the anterior third. A small fenestra avoids also the release of proteolytic enzymes into the labyrinth. It allows reconstitution of the good compliance and imprints of around the piston. And site of the fenestra, as you all know, in the posterior third of the foot plate, as the utricular and sacule lies anteriorly and more superficially to avoid injury to the utricle and sacule. Then stapedius tendon is to be cut, but it preserved in neostapedectomy, which prevents postoperative hyperemesis and rollover phenomena. And then incudostapedial joint is dislocated, then crurotomy. How do you perform crurotomy? Either PIC or by laser. Which crura is to be fractured first? The posterior crura, because it is short and thick in comparison to anterior crura. Removal of the stapes superstructure, avoid direct suction over the vestibule, open vestibule. How will you manage if entire foot plate comes out? In such case, 0.6 mm piston is to be used over a vein graft or perichondrium to seal the oval window. Then prosthesis is to be applied. Why blood should not allow to enter inside the vestibule? The operative field should remain dry. The suction of blood or perilimb from the oval window is significantly associated with high frequency SNHL. Moreover, disintegrated RBC contain potassium ion, which is very much toxic to the perilimb but not to the endolimb. Then piston is to be placed after proper measurement, not too long or not too short piston. There are various ways for calculating the piston. A plus B plus C before opening the vestibule. If you measure the length of the piston before opening the vestibule, A means length of the piston, B means thickness of the foot plate, and C is length of inside the vestibule. But the thickness of the foot plate B, it is varied from person to person in otosclerotic patients. So measuring the length of the piston after opening the vestibule, as the thickness of the foot plate varies in otosclerotic patients. So you open the vestibule first, then you measure the length. You will get the actual length of the piston without doing any mathematical calculation. The piston should project 2.5 millimeter inside the vestibule. If it is more than 0.5, the condition will be hazardous condition producing vertigo. Not too long or not too short piston is to be measured. The piston is to be held in this fashion. Now crimping of the loop of the piston is important, but there are some pistons which doesn't require any crimping. You may be asked in the oral table, name some piston where crimping is not required, particularly platinum clip piston or gold clip piston where crimping is not required, and alloy piston, alloy of nickel 45%, it is called nititol, and titanium 55% where crimping is not required. Now piston insertion is a challenging part. First we have to insert the shaft of the piston inside the hole, then the open loop of the piston is to be negotiated in the long process of the incus, then crimping is to be confirmed by lifting and tilting test. Gently palpate the incus in medial to lateral direction to mobilize the piston in and out of the vestibule to assess for any vertigo, etc. If the patient complains of vertigo, that means piston is a long one. Similarly, bending test, shaft of the piston is moved from back and forth, anterior to posterior or superior to inferior. During this procedure, note whether it tends to come out of the fenestra. If it comes out, it suggests short processes. So in this way, you have to confirm your actual size of the piston. Now, what are the materials we use for sealing the fenestra? Various materials are being used like vein, fat, gel foam, blood, etc. But subcutaneous tissue from the post-auricular groove is the ideal choice, and it should be introduced by non-touch technique. That means the tissue should not touch your gloves, should not touch other instrument, should not touch inside the canal, directly inside the vestibule to prevent foreign body granuloma. Post-operative period audiometry should be done at least after 1 month to check. What are the different types of processes? This question you may be asked. So various material are there, but the piston should be biocompatible, corrosion resistant, and should not cause any allergic reaction. Varied design, various diameter are there. There are some heavier piston like steel and gold, 12.5 milligram to 10 milligram, produce better outcome in the lower frequencies. But lighter piston like Teflon, its weight is 3 milligram, same as Stepis weight. Stepis is about 3 milligram in weight, and Teflon is also 3 milligram. It causes better in higher frequencies hearing outcome. Why slimmer piston are less efficient? Another question commonly asked. Although the hydraulic ratio is better with slimmer piston, the slimmer piston move less perilymph and are less efficient, and it has been proved audiologically. What are the instruments of choice of making fenestra, small fenestra? Perforators of different sizes, 0.3 to 0.4, 0.5, etc. And some use micro drill, some use skitter, some use laser, but perforators, the tactile sensation of the surgeon is very important. So most of the surgeons are doing the small fenestra with the help of different sizes perforator. New developments of stapes surgery as stapidioplasty, stamp is already described, vein interposition, posterior cross on perichondrium, and cartilage. Some may use cartilage also instead of other piston. Congenital fixation of the stapes. You may be asked, how do you differentiate congenital fixation from stapedial otosclerosis? From your history taking only. These 3 points are to be said. It is a childhood or adolescence, but stapedial otosclerosis is usually present in the young adult. Non-progressive, but stapedial otosclerosis is a progressive. No family history in this case, but family history may be present in there. Besides this, there are other differences. Here, whole the stapedius tendon may get ossified. Footplate margin and annular ligament are not easily distinguished in congenital fixation, and there may be chance of prelim gusher is commonly associated. Some difficult situation during stapes surgery, obliterative otosclerosis, incus necrosis, incus dislocation, perilymph, gusher, fistula, malleus fixation, reparative granuloma, persistency stapedial artery, fractured and floating footplate, and overhanging facial nerve. From in this list, any question you can be asked. Now, obliterative otosclerosis, can it be diagnosed before surgery? Answer will be CT scan may help us. Early hearing impairment from the history in teenagers and young adults. In case of juvenile otosclerosis, a positive SWOT sign may be there. Bilateral rapid progression of hearing impairment. Low compliance in tympanometry. If it is obliterative one, the thick footplate is drilled using 0.6 millimeter diamond bar or contralateral handpiece, 800 RPM, or skitter drill and hand bar to look for blue lining of the footplate. And then control fenestra is to be done. If there is incus necrosis, how will you manage? It will slip out. If you put piston, it will slip out in. So IRP, incus replacement prosthesis is the ideal choice. That means from malleus to vestibule, malleovestibulopexy is to be done. If there is incus necrosis, hold the long process and the lenticular process are necrosed. How do you manage if there is incus dislocation? Similarly, if incus is completely disarticulated, remove the incus and perform Maliovestibuloplexy, or sometimes TORP, you can use TORP also. Most common cause of sensorineural hearing loss following stapedectomy. Here your answer will be perilimb fistula. And regarding perilimb fistula, it may be early or delayed. How can you diagnose? How do you manage perilimb fistula? These are the questions to be asked. How perilimb fistula is formed? Inadequate closure of the fenestra. If a post-stapedectomy patient complaining of fullness in the ear for 1 month at least, always think about perilimb fistula. And gel foam is the offending agent nowadays. Why gel foam is not being used as an oval window seal? Because gel foam may be reabsorbed before the neoendosteal membrane has formed. Gel foam may be softened by the perilimb itself, and the processes will penetrate through the gel foam, causing a perilimb fistula. And number 3, the endosteal membrane that forms with gel foam is very thin, and there are formation of many microfistula, which leads to a big perilimb fistula. The causes of delayed perilimb fistula, always ask the patient not to fly, not to go to a mountain, etc., to avoid barotrauma. It is one of the cause of delayed perilimb fistula. How does a perilimb fistula form? CSF in the potential communication with perilimb if there is a patent cochlear aqueduct, and hence CSF pressure is directly transmitted to the perilimb. So in the lumbar spine it is 150 millimeter water, and in the cochlear aqueduct it is 350 millimeter water, and due to repeated eustachian tube blockage, pressure, middle ear pressure will be minus 600 millimeter water. So potential gradient will be 950 millimeter water is developed, which can push the perilimb out of the vestibule, causing perilimb fistula. How to evaluate a case of suspected perilimb fistula? From the history and audiologically, it can be proved. And fistula test, it is usually negative in case of perilimb fistula. If you do fistula test with the help of pneumatic otoscopy, it will be negative. But if you perform the fistula test with the help of ENG, it may get positive. But it is a debatable road due to lack of sensitivity and specificity. How can a perilimb fistula be prevented? Always ask the patient not to fly, not to go to a mountain, cough and sneeze with open mouth. These are the list you should advise to your patient. How do you manage a case of perilimb fistula? It is a surgical emergency. You have to look for the site of the perilimb with the help of gel foam. If you place a dry gel foam here, it will get moist. If you place the clinic test, glucose test, it will turn red. If there is perilimb fistula is there, laser is to be applied for complete excision of all the fistula tract, and then again you have to perform another perform. So bed rest for 48 hours is essential. When does a post-stapedectomy patient can perform scuba diving? Often patient may ask you. Some recommend total abstinence, but if the patient can pass one test that is called tympanometry pressure, if you raise the pressure 400 millimeter of water, will produce nystagmus which corresponds to the maximal displacement of the prosthesis up to 0.2 nanometer, 0.2 millimeter or 200 nanometer. If the patient pass this test, if there is no nystagmus at this pressure and the tympanic member looks normal, diving or parachuting or any other leisure activities, scuba diving, parachuting can be easily advised. How do you explain presence of vertigo in the immediate postoperative period? On the following day after operation, serous labyrinthitis develops as a part of healing process. Symptoms resolve within a few days and without any sequelae. And torn Risner's membrane, which makes sudden drop of cochlear action potential, may cause immediate postoperative period vertigo or imbalance. Similarly, what are the causes of perilimb gusher or oozer? Abnormal communication between the subarachnoid space and the perilimb through the defect in the modulus or piriform plate of the cochlea. This is one of the most important cause of perilimb gusher. It can be identified from before with the help of CT scan. So here lies the question, do you perform CT scan in all cases of stapes surgery? Answer will be yes. About 0.5% of cases, perilimb gusher may be there due to abnormal communication between the subarachnoid space and or abnormal patency of the cochlear aqueduct or defect in the fundus of the internal auditory canal. These are to be identified from CT scan before doing any stapes surgery. Similarly, in case of fixed malleus syndrome, our treatment of choice will be IRP or TORC or malleovestibulotomy. Reparative granuloma, what you put around the piston is not important, provided precautions are taken to avoid foreign body granuloma. And the symptoms, the clinical features of reparative granuloma, just same as Meniere's disease. Persistent stapedial artery, very, very rare condition. If it is present, that means a communication between the middle meningeal artery and the intercarotid artery, and there will be absent foramen spinosum, and the operation is to be abandoned. Nowadays, it is said that. Similarly, fracture of floating footplate may occur. What do you mean by floater? Footplate loses its attachment to the annular ligament during removal of the superstructure, or while making or widening the fenestra. It may also occur when mobilization done on partially fixed footplate. Overhanging facial nerve, one of the condition, it may be maximum overhang if there, you may abandon the procedure and ask the patient to add a hearing aid. No other option. It is the failure due to second arch cartilage to fuse with the otic capsule for causing bifid facial, abnormal course of the facial along the stapes or the promontory, etc. may be there. Complications already said. And what are the criteria of revision operation? A patient to be informed in the preoperative counseling, re-operation sometimes may be needed. Persistent conductive hearing loss, anticipated perineum fistula, 20 dB AV gap. But you should wait for 6 weeks after the primary surgery. And revision surgery may be process related, may be oval window related, it may be again refixed, then revision surgery is required. What are the indications of laser? Nowadays, laser is one of the important tools. It may be used in primary operation also. In revision cases, in obliterative cases, advantage to make a precise fenestra, good hemostasis, and good long-term results. An adverse situation to abandon the operation, already we discussed, these are the list when operation may be abandoned. So in preoperative counseling, these things should be explained to your patient. That means operation may be abandoned. Here lies the role of CT scan. Now, role of cochlear implant in far advanced otosclerosis, or nowadays it is called advanced otosclerosis, cochlear implant may be indicated, particularly in grade 2 and grade 3, implant may be done. But increased risk of facial nerve stimulation due to current leak through the spongiottic bone, causing facial nerve paralysis. So these are the few questions I have collected from different books or from different examiners across the country. Besides this, there may be other questions also. You should prepare for that. So good luck to everyone.
Thank you very much, sir, for the detailed discussion. Now the last session, today's last session is for the specimens, but prior going to that, I would like to request, as Borman sir said, the living legend of stapes surgeon is here. So sir, please say some words to the aspiring ENT surgeons and please wish them luck.
Sir will say about stapes surgery regarding some tricks, how to answer in the examination. And believe me or not, I passed MS ENT under sir, probably in the year 1996, and sir has asked few questions of stapes. One of them was congenital friction of the stapes. How to diagnose clinically a congenital friction of the stapes. Sir, boshe bol.
In fact, I will ask you whether any one of you have done this surgery or not. Otosclerosis. All of you must have seen, isn't it? So how do you feel? Is it very easy or not? Jara jara dekhecho, what you felt that the operation is very simple, easy. But nowadays, in our time, it was not that easy because our bosses and also the books at that time from the international arena, the legends of ear surgery. If I name, say, Sambo's, you must have heard Sambo's ear surgery. In fact, that is the book which helped me to learn the ear surgery. And at that time, there was no specialist in Calcutta at least who could guide a young surgeon like me or aspiring surgeon who wanted to take up the course of otology especially. But at that time also, the people used to do the surgery. And if I will request Dr. Chopin, can you just put your evolution of surgery that you have put that slide? Because if you see that, the first one was the Rosen's mobilization of stapes. There was the fixation. You know the surgery, you know the pathology, and it causes fixation of the foot plate of stapes, and that is the pathology. Mostly it occurs in fistula antifenestrum, near the anterior crus, involving the anterior crus first. Then it spreads all over the foot plate, and there may be different stages of the fixation of the foot plate. So, I started my career when Rosen's mobilization operation was in vogue at that time. Only people used to do Rosen's mobilization operation. And I have seen many done by boss in my hospitals. I assisted them. I did later on. And I saw some author, Rosen, Samuel Rosen. Have you heard the Rosen's? It is his operation. And he also actually accidentally developed this. Just for seeing, go through the middle ear to the microscope, he saw that after moving stapes, patient started hearing. Then he thought that, why don't you do this? That is mobilization. Then he used to roam about all over the world to demonstrate his surgery of mobilization. And do you know why it is not done nowadays? What has become obsolete? Could you guess anything? Because it's a progressive disease. You just mobilize it and it is just moving for the time being for about 1 month, 2 months, 3 months, 6 months. After that, again, it will come back. So that operation has become obsolete now. Then came piston operation. That is, then came this total stapedectomy of Shea. Shea also actually did this surgery accidentally while he was doing in the middle ear, some middle ear surgeries. He saw that suddenly he made a hole onto the foot plate of stapes and patient started hearing. Then he communicated that fenestra on the foot plate with the incus. That is the total stapedectomy. I did total stapedectomy in my life, and that was the system that you will have to remove whole of the foot plate. So in most of the patients used to have a lot of complications in the form of vertigo, postoperative vertigo, loss of hearing after some time, so on and so forth. So that also has become obsolete nowadays. Nobody does total stapedectomy nowadays. Then partial stapedectomy started. Then small fenestra stapedectomy nowadays, everybody is doing all over the world. That is Shea's in 92. Again, that Shea, he developed this small fenestra. Because if you do large fenestra and use 0.8 millimeter piston, and that was the standard piston at that time, and that 0.8 millimeter piston, after doing total stapedectomy, we used to saw that there were a lot of gap remains in the higher frequencies. So total closure of the earbone gap after the surgery never used to get. Then came small fenestra. What is small fenestra? 0.4, 0.5, 0.6, 0.7. 0.8 is the standard piston. It is not done nowadays, not available also in the market. And then out of all these 0.4, 0.5, 0.6, which one is better? I am using 0.5 nowadays. And in 0.5, if you use, in all the cases you can do, if you do a successful surgery, there is a complete closure within 10 decibel of bone conduction and ear conduction by using 0.5. If they ask in your exam during this oral examination, you can say that 0.4, 0.5. Most of the time, 0.4 piston is not available in the market. So 0.5 is the ideal piston by which you can get closure of the airborne gap in all the frequencies, starting from 500, 2000, 2000, 4000 also. So that is about the small fenestra piston. Then came the reverse stapidotomy. And you have seen the operation shown by Dr. Sopan Ghosh. You have seen, you open the, I have got it. এটাকে লোড করা যাবে একটা অপারেশন আমার এতে আছে যদি দেখো তো লোড করে ও সো টাইম ইজ শর্ট ওকে না পরীক্ষায় দিতে গেলে অনেক কিছু বলার আছে তো সব অত বলা সম্ভব নয় এনিওয়ে ফর স্টেপিস সার্জারি what is reverse stapidotomy? They might ask you because you are a postgraduate examinee. What is reverse stapidotomy? He has told. Can you anybody say that? What is reverse? What is the normal stapidotomy? You open the incudostapedial complex, expose that, then you cut the piston, then you dislocate the incudostapedial joint. That is the way of usual procedure. The reverse is, you put the piston first, then you cut the stapedius tendon, then you dislocate the incudostapedial. Then the other way round. That is the reverse stapidotomy, and that is the best way. Because if you put the piston with fixed incus, incudostapedial complex, it is very simple to put because you are putting a piston in a stiff fixed incus. So you can easily put that. And those you have seen, you must have seen somebody must be having some difficulty in putting the piston onto the incus. Sometimes it becomes difficult. So that is reverse. And neo is my technique. All of you know, if you cut the stapedius tendon, you have heard so much of reflex, stapedius reflex there, since morning. I'm also hearing that. There's a lot of importance of the stapedius tendon. Why you cut it? So if you cut it, you are not getting the function of, what is the function of stapedius tendon? It contracts, makes the chain fixed. It doesn't allow the injurious sound going to the inner ear. So it has importance. You cut the incudostapedial joint. Do you know the supply of the incudostapedial joint of the incus? Incus, lower part, above the lenticular process have got no blood supply. There is no blood supply directly in that particular part. That gets supply from the anastomosis formed all around incudostapedial joint. And blood vessels coming from four parts, anterior crus, posterior crus, log process of incus, and stapedius tendon. These are the four arteries come and make an anastomosis on the incudostapedial joint. From that part, lenticular process gets supply. Naturally, if you cut the incudostapedial joint, you are cutting through all the anastomosis. And that's why you get so many cases, the necrosis of the lenticular process. That is one of the complications. That in the postoperative period, after doing a good surgery, successful surgery, you will see that patient is again having same complaint due to that. So there are so many other reasons by why the rollover phenomena. What is the dynamic range? Do you know? This is for post-graduation. What is dynamic range? Dynamic range of the sound, dynamic range of the light, everything has got dynamic range. So in relation to stapes surgery, what is dynamic range? Dynamic range is a difference between normal sound and high frequency sound. The range between these two is the dynamic range. So if you cut the stapedius tendon, the function of stapedius tendon as because it's not there, dynamic range becomes lowered. Patient gets lot of vertigo, lot of long time dizziness and so on and so forth, and get what is that called? Sound gallage. Yes. So all these things can happen. There are so many things to know. So thank you so much. There is less time, so I can't help you in any way. And I had a video also of the operation of my own done on 16th of March. And if I get chance, I will show you later on. Okay, thank you.
থ্যাংক ইউ স্যার। স্যার এই বয়সেও এসে নিয়েও এই বেলা অবধি তোদের অ্যাড্রেস করছে, আমি বলবো এটা তোদের ভাগ্য। আর আমরা স্যারের ক্যাডাভার ডিসেকশন দেখেছি, আমরা স্যারকে রিকোয়েস্ট করবো স্যার ওই ভিডিওসগুলো দিয়ে দেবেন, আমি ওদের ওরিয়েন্ট গ্রুপে শেয়ার করে দেবো। আচ্ছা, লাস্ট সেশন উইল বি বাই ডক্টর সৈকত সমাদ্দার অ্যান্ড ডক্টর রাজীব সিং অ্যান্ড ডক্টর দেবাংশু ঘোষ অ্যান্ড অন দি স্পেসিমেন্টস। চলায় সৈকত।
আচ্ছা, একটা কথা বলি সবাইকে, সেটা হচ্ছে একটা ফিডব্যাক ফর্ম দেওয়া হয়েছে। সো প্লিজ ফিল আপ দ্য ফিডব্যাক ফর্ম অ্যান্ড গিভ ইট টু আস। ইফ ইউ হ্যাভ এনি ডাউটস, এনি কোয়ারিজ, ইউ ক্যান রাইট দেয়ার। If you have any suggestion, you can provide us. এই যে ক্লাসগুলো হচ্ছে, এই ক্লাসগুলো হচ্ছে তোদের ডাউট ক্লিয়ারিংয়ের জন্য। এটা একটা মানে it is an effort to bring all the faculties, all the examiners who will be your examiners in a common platform where you can interact with them. Because in your college you will not get all the professors, all the examiners there. So you are getting all of them in a common platform. And you are all, I hope you all have joined the WhatsApp group. If anyone have not joined yet, please join the group. We are sharing all the PPTs there, and we will upload the videos of the lectures in our YouTube, so where you can review them. And if you have any doubts in future, then you can also share it in the WhatsApp group, where the teachers will give you the answers. Okay.